All right, good morning, everybody, or afternoon, really. This is CSOC partnership with Colorado Department of Public Health and Environment, understanding meningococcal disease, epidemiology in Colorado, and disease and control strategies. Presenter today will be Aaron Youngkin. If you want to go, who is a vaccine preventable invasive diseases program member with the Division of Disease Control and Public Health Response for CDPHE. If you'll go to the next slide for me, thank you. These trainings are designed for both healthcare and non-healthcare staff, and this is again in partnership to provide a series of trainings on infectious disease prevention for our jails and other entities. This training will be and is being currently recorded. Please mute your microphone to avoid background noises. If time permits, the presenters will answer questions following the presentation. At that time, you can submit questions using the chat feature by clicking the raise hand to speak. Participants will receive an email in the next 2 weeks with instructions for accessing a copy of the slides, the recorded presentation, and a brief evaluation survey. The evaluation survey is also linked in the webinar chat window. It's very important for us to get these surveys back. So if you are attending this presentation, please do complete the survey for us. This will also be posted on the County Sheriffs of Colorado YouTube page once it's approved by Department of Health. So we do recommend that you do share it to other folks if you like the presentation or they feel that they need the information. It will be available probably within the next few days. I'm guessing by the beginning of next week, the way that has run in the past. And without further ado, Aaron, please go ahead and thank you for your time.
All right, thank you. Hi all, my name is Aaron Youngkin and I'm part of the Vaccine Preventable Disease and Invasive Disease Program here at CDPHE. We put together today's presentation to understand meningococcal disease, the current epidemiology in Colorado, and then talk through some disease control strategies. So these are our objectives for this presentation. I'll let you read them briefly on your own. Okay, so let's start with some background information. Meningococcal disease is pretty rare but very serious infection caused by a bacteria called Neisseria meningitidis. We think about 10% of the population actually carries this bacteria in their noses and throats. For most of these people, this doesn't cause disease. However, when this bacteria gets into places that don't normally have it, it causes invasive disease. And invasive meningococcal disease can cause things like fever, fatigue, headache, stiff neck, sensitivity to light, and an altered mental status. Like I said a couple seconds ago, this is a serious infection, as complications of meningococcal disease can include meningitis, pneumonia, and infections in your bloodstream and joints, and death. So meningococcal disease usually has a rapid onset. While the incubation for the disease is anywhere between 2 and 10 days, most people start feeling sick within 4. People with the disease are infectious for the 7 days prior to their symptom onset until 24 hours after antibiotic treatment has begun. The bacteria is transmitted person to person through droplets or contact with nasal and oral secretions, which requires some pretty close contact. Think things like kissing or sharing a vape pen, for instance. And here there's a lot of information and I won't read it all, but this slide really illustrates the different presentations of meningococcal disease. And I think the main takeaway here is that meninge does not always present as meningitis. And no matter the symptoms, immediate medical attention is necessary to prevent further complications. Testing for Neisseria meningitidis should occur in normally sterile sites only. So most commonly those are blood, cerebral spinal fluid, or joint fluid. And there are a few different tests we use to identify the bacteria, those being gram stain, culture, and PCR. And then our state lab actually does the last one, which is serogrouping, and that identifies the strain of bacteria that is causing disease. And this allows us to identify cases that might be related and observe trends over time. And I think here, just to note, testing of non-sterile sites like using NP swabs or sputum is not indicative of meningococcal disease. And those tests are common for things like COVID or flu. There are 6 strains of the bacteria: A, B, C, X, Y, and W135. And then 1 additional non-groupable category. We do have 3 licensed vaccines available. Each covers only certain strains of meninge, which can be determined by the letters following the men for each of those. So for instance, the first covers the A, C, Y, and W strains. And while adolescents and some very specific groups routinely get vaccinated for meningococcal disease, most adults are likely unvaccinated. In addition to vaccines to prevent disease, we also recommend post-exposure prophylaxis, or PEP, to close contacts of cases. And I'll talk about that a little bit more later on in the presentation. All right, so let's move on to the current epi of meningococcal disease. This is an epi curve, and it shows what meningococcal disease in Colorado has looked like for the past 10 years. We have had relatively stable case counts since 2017, and rates pre-pandemic and actually during the pandemic. And we had seen about 6 to 7 cases per year since then. But things have really taken off in the past year, and we ended 2023 with 17 cases. And so far, 2024 year to date, we have had 12 cases. A deeper look into the 2023 cases shows that we've had 2 deaths occurring among cases, which is an 11% case fatality rate. 3 cases were among people experiencing homelessness, and we did not see that any one strain of the bacteria was more predominant than the others. And we're not alone in Colorado. This increase has also played out across the country. Nationally, the increase was seen in the Y strains, and more specifically, the Ys that are genetically called sequence type 1466. In Colorado, we had 2 of those cases last year. And nationally, disproportionately affected populations include people between the ages of 30 and 60 years, those who are Black or African American, and people living with HIV. One of our 2 1466 cases last year fell into one of those categories. And one theory we have about this huge increase in meningococcal disease is that natural immunity to it decreased during the pandemic. And the primary way that we can control the spread is through vaccination. And finally, over the past year or so, this is what we have seen for cases month to month. Since the beginning of this year, we've seen a big increase in cases with strain Y, and it is disproportionately affecting people experiencing homelessness. So how do we investigate to help mitigate the spread? Graphically, here is our timeline of disease investigation events, and I'll go into greater detail in the next few slides. So during an investigation, we start when public health is notified of either a suspect case, or those with only gram stain testing, or a confirmed case, which are those who have a culture or PCR test. For suspect cases, we determine if the case seems clinically compatible, as not all gram stain tests or reports of meningitis are actually meningococcal disease. And the disease control recommendations vary if it is not Neisseria meningitidis. Then public health interviews the case where possible, or other proxies to determine when the onset date of symptoms was. And like I previously mentioned, the infectious period starts 7 days prior to the onset of symptoms and will last until 24 hours after an antibiotic treatment has begun. In that infectious period, we determine who were close contacts of the case and recommend post-exposure prophylaxis to those people. And in correctional settings, you will likely be working with local public health agencies to complete these steps together. But I wanted to make sure that these steps were outlined so you understood them and could get to work on disease control as quickly as possible. And a note on the last two steps: a close contact is any person who had contact with the case's respiratory secretions or saliva. So this would include household members and those who share sleeping spaces, teammates, and significant others, and anyone who may have shared things like drinks, cigarettes, or vape pens with the case. And ideally, these individuals will get PEP as soon as possible, but it is not recommended after 14 days following exposure. The recommendation for PEP is 1 dose of Cipro, and alternatives are available for those where it's unavailable or contraindicated. Next, I wanted to provide a guide to where available resources live. The CDPHE communicable disease website is a great place to start. Info about meninge can be found by clicking on any of the circled links. And then here I've linked the URLs and links to the web pages for meningococcal disease on the CDPHE and CDC websites. Additionally, I put our team email on there, and my team and I are always available to chat or answer any questions as they come up. So in order to start brainstorming how your facility might respond to a case of meningococcal disease, I wanted to pose this question. Suppose a case of meningococcal disease is identified in your facility. Working with public health partners, who would you identify as someone needing PEP? Would it be visitors, facility staff with no contact to the case patient, or cellmates or others sharing the same sleeping space? And I'll give you a few seconds to think on that, and feel free to put any guesses into the chat if you like, but you don't have to. Okay, so the answer here is C. Cellmates are those sharing a sleeping space with the case. Visitors with limited contact likely do not need PEP, as do staff who do not have contact with the case. And you may have started to think about who else may potentially need PEP. And ones that come to mind for me might include staff who are involved in the emergency medical response with the case, or anyone who might have shared cigarettes, utensils, etc. Again, public health can help determine who is a close contact in each investigation. And so we've learned that meningococcal disease is a serious infection that occurs quickly and requires immediate medical attention. And a single case of meninge can require swift coordinated efforts to provide PEP to close contacts. And this was a pretty short one, but I want to thank you so much for listening. I'm happy to take any questions. And we are always available by email to answer as well.
Great, thank you, Erin. Looking through the chat to see if we have any questions in the chat. It looks like no questions so far. Your contact information is there. One more opportunity for someone to grab some questions if they have any, and then we'll go ahead and conclude the presentation. All right. I don't see any questions, Aaron and Brianna and Jamie. Thank you so much for putting on this presentation with us. I appreciate it. This will again be posted on our YouTube page as soon as CDPHE approves the recording. And please feel free to get in touch with us or TPHE for a link, which is also in our chat. Thank you so much for your time today, and have a wonderful day.